I these days take such comfort in that robot voice telling me that the recording is in progress because it tells me that I pushed the right button setting the link up. All right, folks. Well, you've almost certainly been to sessions before this, so you know my style of kind of ad-libbing and monologuing until we get more folks in the room as you're transferring from the waiting room. So bear with us for just a few more moments as we get that participant list up. All right, well, I'm seeing the increase kind of peter out, so let us get going. Folks, we are on our last day of our overdose awareness series. So we have this and one other session today before we close out for this year. Thank you all so much for joining today. Typical housekeeping before I introduce our guest speaker. Reminder to ask questions throughout as you have them in the Q&A box. Reserve the chat box for sharing of experiences, introduce yourself if you'd like, ask tech questions there, share resources, that kind of thing. But that helps us moderators kind of keep track of everything as we're going through the session. And a reminder, you're going to be so tired of me saying this, but if you do want that certificate of attendance, fill out our survey when you finish your sessions for the day. So we'll go ahead and get that posted in our chat box. All right, enough of me. Let's get going with our guest speaker today. I am super excited to introduce Liz Wolkin. So Liz is a certified emergency nurse and nursing educator who manages the Healthcare Authority's Scala Northwest Emergency Department Bridge program. They are a lifelong harm reductionist and has lived experience with substance use disorder. Liz, thank you so much for being here, and I'll pass it on to you. Take it away.
Thank you so much, Alex, for having me, and thank you to all of you for coming out and chatting about this really important stuff. Yeah, so my background is in emergency nursing, so worked in the emergency department as a charge nurse and an educator, and then also have that harm reduction and lived experience component. And I'm going to be talking a little bit today about medications for opioid use disorder in the emergency department setting. Kind of the value of them and how we can increase access to these medications in the ER. So since we're talking about MOUD, I just want to really quickly talk about the options for these medications and then which ones or how they work in the ER setting. So there's really 3 FDA-approved medications, and we've got methadone, buprenorphine, and naltrexone. Methadone is a full agonist opioid, so it fully activates the opioid receptors in the brain, which means you have full effects, including euphoria, but also respiratory depression. It treats withdrawal and cravings, reduces mortality, but can only be accessed in a specialized opioid treatment program or methadone clinic setting. Because of this, it can absolutely be used in the emergency department, but there are some limitations and some challenges specifically around coordinating care. And there are many regions that don't have a methadone clinic or an OTP for patients to follow up in. Naltrexone is an opioid antagonist. So it blocks opioid receptors, but doesn't activate them. So opioids cannot activate them, but also the effects aren't there. So it doesn't treat withdrawal. It may treat cravings in some people, for other people it doesn't. And the evidence shows that it doesn't reduce mortality. So it doesn't lower folks' risk of death. It can be prescribed, picked up at a pharmacy, but because it doesn't treat withdrawal, which many people are in the emergency department, and doesn't have that same reduction in mortality rates, it's not always the best choice for the emergency department either. So when we're talking about MOUD and the ED, we're really focusing on buprenorphine. Buprenorphine is a partial agonist opioid, which means it binds to your opioid receptors, it activates them, but the effect is weaker than full agonists like methadone or fentanyl. There's not as much of a euphoric effect, and there's also not that same risk of respiratory depression and overdose. Buprenorphine treats withdrawal and cravings and reduces mortality. It can also be prescribed, picked up in a pharmacy, so accessible in a wider range of emergency departments and communities for follow-up. So for the purpose of this presentation, when we're talking about MOUD and the ED, we're focusing on buprenorphine. So, what is the emergency department for in a bigger picture sense, right? Outside of the setting of opioid use disorder, but just in the fabric of society, right? Why do we have them? Emergency departments are there to see any patient anytime. So has to be 24/7, has to be always open, and can't turn anyone away. So that's a really, really important part of what emergency departments do. They can't deny care if you don't have insurance. You can't deny care based on citizenship status. Legally, anyone who shows up has to be seen by a provider, has to be evaluated for anything life-threatening, stabilized. This is a life-saving service, and everyone can access it 100% of the time. That makes this a safety net, right? So if you don't have a primary care provider, if you can't get into one, if you can't afford access to certain medications, whatever it is, and you are critically ill, you can go here. And that, not only is really important on an individual level, but also in the bigger picture of our healthcare system. If we don't have emergency departments, we don't have that place that people can go to, that people can be safe, that people can come to with critical illnesses, with life-threatening illnesses. And so knowing that they are there is something that's so important for our healthcare system and for individuals. And that's what the ED is for, right? To save lives for any patient, anytime. So a typical encounter is someone's going to come to the emergency department, and what we're going to do is triage them. We're going to look at our patients, everyone who's there, and say, we don't have appointment times. We don't see people on the order that they show up to the emergency department. We're going to see the sickest patient first. We're going to make sure we're focusing on those patients who could deteriorate, who could die, right? And so we're going to triage. We're going to find those patients who need an immediate intervention, something to stabilize them, something to keep them alive, to help them breathe, to keep their heart beating. And keep in mind, when someone comes to the emergency department, the emergency department doesn't always know what's wrong. And we don't have to, right? Like, we are there to triage, to stabilize. And then we want to figure out what the condition is, a diagnosis. What brings you here today? What made you sick, right? Part of the role of the emergency department is to stabilize someone, to bring whatever their condition was to the point that it can be managed, to lower their risk of death and of harm, to treat symptoms like pain, pain, nausea, whatever it is, make sure that we get that under control and then figure out what the next steps are. Folks don't stay in the emergency department. They come to it so that they can go somewhere else. And maybe that's, being transferred to a trauma center. Maybe that's being admitted to the hospital. Maybe that's being discharged and, linked to care with a primary care provider. But we're going to make sure and bridge that care and keep that person safe from the time of discharge till they go where they need to be for follow-up. And sometimes that looks like coordinated handoffs with ambulances and EMS and transfer to OBGYN. And sometimes it means writing prescriptions, referrals to follow-up appointments, to imaging, whatever they need to make sure that they can stay stable. And then we want to make sure they don't come back, right? So part of the role of the emergency department is also to prevent further critical illness. And when we're able to do that, that goal is someone goes from sick, gravely injured, critical condition, and onward, right, to establishing healthcare, to wellness, to recovery. When patients come in with an opioid overdose, that same process gets disrupted. So someone may come in and we can triage them. We can say, you're sick. maybe you're not breathing, we're going to give naloxone. So there's that intervention, that immediate response to, try to save someone's life. We can reverse that overdose. We can diagnose it. We can say this is, this is opioid poisoning. This is opioid use disorder. And then and then not always, but then emergency department skips some steps. So in other conditions, we're going to say, let's stabilize this. Let's address the underlying cause. Let's get your symptoms under control. Let's, connect you to care. Let's prevent you coming back. That doesn't always happen for an opioid overdose patient. Symptoms aren't always managed. Long-term care isn't always established. But prescriptions aren't always offered. And so what we're seeing instead is someone's going to come in, we're going to do that intervention, that, naloxone, reverse the overdose, and stop there. So when folks are discharged, there isn't a setup for them to move down that path towards wellness, towards health, towards recovery. And instead, the cycle continues. They're gonna get sicker. They're at risk of having another near fatal event, coming back to the emergency department and starting all over. So we are no longer kind of creating a process where someone's moving forward in care, but they're cycling through in the emergency department. And that's not the goal for our ED or for our patients. This also creates kind of emotional harm, both for patients and for providers working in the emergency department. And so someone comes in for an emergency department visit, they've had a non-fatal overdose, they are really sick, they nearly died, and then they may not get treatment. If medications for opioid use disorder aren't initiated, the patient's going to have withdrawal. They've been given naloxone, their opioid receptors are blocked. They're going to get sick. These worsening symptoms don't get treated, right? So there's excruciating pain, right? This is extremely, extremely painful. And also a lot of fear about why, knowing that other patients aren't left to suffer those kinds of symptoms. Wondering or assuming that the reason that they're in so much pain and it's not being addressed is because of their opioid use diagnosis and the associated stigma. If they didn't come in with an overdose, but came in with, abdominal pain, a skin infection, a lot of times patients aren't believed. So sometimes that pain is distrusted. Oh, this is someone who is, drug seeking. The conditions are distrusted. Maybe they're not sick at all. And so there's a lot of fear as well. Fear that they won't be taken seriously. Fear that there could be a really critical condition or illness that the emergency department isn't looking for, isn't going to find. So this is really scary. It's really uncomfortable. There's shame, like internalized shame. Um, it- and all of that creates this lack of trust, right? I don't I don't believe I'm getting care. I don't believe the healthcare system is here for me. Um, I'm going to avoid this wherever possible, right? Or even if, a patient is offered care, hey, you do have that infection, right? You do have something going on. You do need surgery or to be admitted to the hospital. If withdrawal isn't treated, if pain isn't managed, right, if symptoms aren't addressed, then a lot of times that patient isn't able to stay for care. They can't tolerate the conditions under which they're being asked to continue their medical treatment. That again creates that lack of trust and that sense that no one else would be treated this way, and I'm not safe here. Then patients either discharged for that non-fatal overdose without that treatment, only having the overdose reversed, but the underlying cause not being addressed, or a patient's going to leave against medical advice prior to medical discharge because they can't tolerate the conditions under which they're in the hospital. That leads to really poor outcomes, right? People get sicker when they don't get the care they need, when they don't get the treatment that they need. These experiences encourage folks with opioid use disorder to avoid and stay away from healthcare systems so that when they next intersect with a provider, it's oftentimes in the emergency department because they're too sick to go anywhere else and may have waited a really long time. We know that many folks with opioid use disorder come to the ED with no other intersection with care. Coming back to the emergency department, the cycle continues for the patient. And it also continues for the providers, right? For nursing staff, for providers who are seeing patients come back over and over again. These providers may not have had experience with medications for opioid use disorder. They may not have been trained or have access to appropriately treat this condition. And they're watching people get worse. They're watching people be sick and aren't able to help, may not have the tools to help, and that can feel really discouraging. There's a feeling of frustration, insecurity, compassion fatigue, the conflict that can arise in these situations, the workload stress of working with a patient whose symptoms are unmanaged. All of this can lead to an avoidance of working with these patients, dissatisfaction with working with these patients. And that contributes to that cycle, leading to poor outcomes, coming back to the ER, and again, going in kind of a loop that is bad for providers and for patients. And eventually, those poor outcomes can look like death, right? So we know that there's a much higher risk of death for patients with opioid use disorder than general population coming to the emergency department. They're sicker when they get there. They're more likely to be hospitalized and stuck in this cycle, more likely to die following the ED visit. In talking about that mortality risk, right, that risk of death, folks who have opioid use disorder are 3.5 times more likely than general population to die following an ED visit. For non-fatal opioid overdoses, that mortality rate is 5.5%. So 5.5% of people who go to an emergency department and have a non-fatal overdose will die in the year following. That's really high. It's really high. So for a heart attack, the kind of common number for 1-year mortality is 7.7%. So we're looking at a critical illness. We are looking at a critical illness that patients are so sick and their risk of death is so high that I can't imagine another diagnosis that goes to the emergency department and may not get that treatment, may not get the medication that can help them. It's also a really young population. So we're looking at folks with a median age of death of 39, so under 40. Really, really high risk. And I think, one thing that I really want to highlight when we're looking at this risk of death is the distribution of when those deaths occur. So the reason being is sometimes we might hear, well, the emergency department can refer people to outpatient care. Maybe we don't need to start medications for opioid use disorder. Maybe, our job is to reverse the overdose, that life-saving intervention, not to treat the underlying condition. However, 1 in 5 patients who die in that year following an ED visit do so in the first month. Month 1, 30 days. So that's 20% in the first month. And over here, this graph, that's showing the distribution of that first month. So day 1 is that really high bar that's higher than all the other ones. That is day 1 following discharge. And I just really, I driving that home again to show when we're not using the tools, when we're not treating the underlying condition, reversing an opioid overdose is not enough in the emergency department, and the ability to refer to care isn't enough either. I want to caveat too, when we're looking at this mortality rate and this distribution of death, this study and similar studies are pre-fentanyl data. or beginning of fentanyl era data. And so it's reasonable to assume that these numbers have gone up since then. So I just want to throw that out there, that we're looking at 2015, 2016-ish when we're looking at these mortality rates. And as we start to get data from, 2021, 22, and 23, it's likely we'll be looking at higher mortality rates following these ED visits. So when we go back to that emergency department role, any patient, anytime, life-saving care, that safety net, I think kind of revisiting, we know that functions for folks who get into a car accident, right? We know that functions for someone who's having a heart attack, someone whose kiddo has, like 104 fever in the middle of the night. Those patients, those conditions trust that the emergency department is going to fill the role that it is designed to, that they can walk in, get what they need. Patients with opioid use disorder may not have that experience. And just to think about the weight of that a little bit is, think about maybe during COVID, when there were times that emergency departments were so overloaded that, the encouragement was don't go if you can avoid it. And a sense of, maybe my emergency department won't be able to see me, right? Like maybe they are at capacity and won't be able to go there. Like I felt a lack of security. And I know that other people did as well, to say, wow, that backup may not be there for me. And so to imagine that patients with opioid use disorder may be feeling that way all the time. There is no safety net for me. Also to recognize when we're looking at life-saving care and when we talk about how high mortality rates are for patients following an emergency department visit, it's also valuable to talk about that intersection with the healthcare system may be the only time a patient with opioid use disorder is in front of someone who can prescribe medication, who can offer buprenorphine. There may not be other intersections with the healthcare system, and taking advantage of this one is part of the role of the emergency department, the safety net role, the life-saving care. It's also a time when a patient following a non-fatal overdose reversal, they are already in withdrawal. Not only does medications for opioid use disorder treat the underlying condition, but it treats symptoms. There's oftentimes a motivation to change. There are studies that show, 70% of more patients after non-fatal overdose make positive behavioral changes that reduce their harm or their risk of harm immediately following that overdose event. So we've got the right place at the right time. And medications for opioid use disorder align with emergency department's role. And it's really effective. It works. So initiating buprenorphine in the emergency department lowers a patient's risk of death after overdose by 63%, just fantastic. It also doubles the retention and treatment over referral. So if a patient starts buprenorphine in the ED, they are twice as likely to be retained in treatment and still on buprenorphine 30 days later than if they are just linked to care without initiating medication. It also reduces future ED visits. So that cycle where, a patient keeps coming back and both patients and providers keep having these negative experiences can be broken. Another thing that, and all of that is really important, and from a patient-centered perspective and a public health perspective, absolutely looking at those mortality rates and retention and treatment. And also, providers who use MOUD describe treating patients with opioid use disorder as professionally satisfying. So I did not hear that a lot in the emergency department or in the hospital setting. Oftentimes, opioid use disorder patients are the least satisfying or the most frustrating for providers when they're not using MOUD. So this shift, I think, is really profound, not only for the implications for the providers and their kind of quality of life and job satisfaction, but also thinking about that stigma, that lack of trust. If a provider walks in the room excited to see this patient saying, "Hey, I can help you," that shift in terms of relationships and relationship to a broader healthcare system can change. So, you know, once providers have tried it, once they have used MOUD or seen other providers use MOUD, that sense of agency and ability to support patients with opioid use disorder shoots up. So buprenorphine is harm reduction. So I think we've talked a little bit about buprenorphine, like, okay, can retain people in treatment, can treat the underlying condition, reduces mortality rates, and those things are all true. And also, I think it's really valuable to talk about buprenorphine not only as a tool to treat opioid use disorder, but as a tool to reduce harm associated with it. So one thing is that buprenorphine treats withdrawal, and you can give it for that. So if a patient is in the emergency department and they've had a non-fatal overdose reversed and were given naloxone and are really sick, they don't have to agree to long-term treatment, to, recovery, to staying on buprenorphine in order to get it for their withdrawal symptoms. And I think that's really important. In the emergency department, we do treat symptoms. We treat pain, we treat nausea, we treat agitation, we treat discomfort. And we can use buprenorphine as a tool for that in patients with opioid use disorder without having that conversation about the long-term engagement and treatment or before having it. It may be that treating withdrawal symptoms facilitates a more productive conversation about long-term goals. It can be very hard for anyone to think about long-term goals or think about the future when you're really, really sick. And so treating those symptoms can set the patient and the provider up to have that conversation. And it's not necessary beforehand. You can also, on that note, prescribe buprenorphine for withdrawal. So someone does not need to sign on to full, yes, I want to enter into treatment and recovery and long-term buprenorphine use. You can offer a prescription to say, hey, if you go into withdrawal, you have this in your back pocket. This is a resource for you. You can try it and see if it works, right? And I think recognizing that ability to use this as a withdrawal prevention or withdrawal treatment is really valuable from a harm reduction perspective. The concern that you may hear from providers around that or may feel as a provider yourself is, well, that's not what it's for. And what if people are, going to use it to get high or recreationally? And I think that brings us back to talking about the mechanism of action. So buprenorphine as a partial agonist does activate those opioid receptors, but not as much. And that euphoric feeling, those feelings of euphoria are typically, not experienced with buprenorphine. And that respiratory depression is blocked, right? And so it can be protective against overdose. A patient can have buprenorphine, they can use buprenorphine, and if they use other opioids or other substances, they could be less likely to overdose because that buprenorphine is blocking those opioid receptors from being fully activated and protecting them from respiratory depression, from slowing or stopping breathing. We also know, you know, concerns about diversion. Well, what if folks sell it? What if folks give it to other people? Maybe that's okay. Diverted buprenorphine is used for its intended therapeutic purpose, right? So people who use buprenorphine that it is not prescribed to them are using it to treat withdrawal symptoms, to reduce opioid use, or illicit opioid use, or to kind of move on a path towards recovery and healthier use patterns, which is the intention of the medication. And 80% of people who use, diverted buprenorphine not prescribed to them, say they would rather get it prescribed, but can't access it because of barriers to access, barriers to treatment, whatever that may be. And so you have a market with buprenorphine in it where people are less likely to overdose and more likely to be using these medications for opioid use disorder the way they're intended. I think these are all, things to consider when looking at buprenorphine as a harm reduction strategy, and offering buprenorphine to a patient is just giving them the same level of care as patients with other medical conditions. And that's harm reduction too. So if the patient doesn't, want to initiate buprenorphine, doesn't want to get a prescription and continue with buprenorphine, just the act of offering it is saying, hey, you deserve medication to treat your symptoms. You deserve the opportunity to treat your underlying condition. I'm going to treat you the way I would anyone else. Builds trust in the healthcare system, reduces that internalized shame that can be associated with being treated, coming from a place of stigma and bias. So just that offer in and of itself can be a harm reduction measure. On that note of treating patients with opioid use disorder the way you would other conditions, I just want to throw out there, right? If someone came in with high blood pressure and you were to say, hey, I'm not going to give you blood pressure medications, this is a lifestyle issue. You should change your diet. You should change your exercise routine. You should do all of that first. I'm not going to give you meds if you're not doing that and if you're not doing it perfectly. That's not how we treat other conditions. We don't expect people with high blood pressure, with diabetes, with heart failure to manage their conditions with no medication, unsupported, just by lifestyle changes. That is not the expectation of the healthcare system. We don't expect people to never eat salt again, to exercise every day. But we expect people with opioid use disorder oftentimes to be completely abstinent if they want access to medication or treatment, to make lifestyle changes, social group changes, go to 12-step meetings, demonstrate this total reversal of kind of how they interact with their health, with opioids, with their social network, and all without medication support. That is not how we treat anything else. And so I kind of want to throw that out there that in many ways, the expectation is a higher standard for folks with opioid use disorder who are also facing greater barriers, and to recognize that we can balance that out. We can accept with opioid use disorder, just like we do with other chronic conditions, that no one is going to be perfectly adherent to lifestyle changes or to these recommendations, and that we're going to support them with medication anyways. From from a technical or clinical perspective, the number needed to treat, I'm going to talk about this a little bit. So what that means is how many people need to receive a medication in order for one person to benefit from it. And this chart here shows a number of medications that hospitals and emergency departments use every time. So magnesium for preeclampsia is a medication used in pregnant patients who are at risk of having a seizure related to their high blood pressure. Anytime a pregnant patient is at risk of having a seizure and has this high blood pressure, we are going to give them magnesium. We are going to do it. There is not going to be a conversation about it. That is going to happen. The goal is preventing seizures. We have to give it to 90 patients for one patient to benefit, right? Giving aspirin for a heart attack. We're going to give aspirin to every patient who's having or maybe having a heart attack. And 42 patients need to receive it in order for one to get benefit from that specific medication. Blood thinners to prevent recurrence of clots. 17 patients need to get those medications for one patient to have that benefit. And we're going to give it every time. For buprenorphine at higher doses, right? So doses greater than 16 milligrams, if you give that medication to 2 patients, one will benefit. So that's amazing. We don't have medications that are that effective um, for lots of conditions. And so buprenorphine is a gift, right? Like the opportunity to have access to a medication that is this effective is rare. And also, we're going to use medications that are less effective every time. But for buprenorphine, estimate is that only 9% of patients are actually prescribed buprenorphine following an ED visit for an opioid overdose. So again, that's a patient who nearly died, who is critically ill, who has this really effective medication, and only 9% are getting it. And that number may be high. There are, some studies show as low as 1%. I think it's really variable depending on the hospital setting. If you're looking at big urban academic institutions versus smaller community hospitals, you're going to get a wide range. But we can put like a median kind of estimate at 9%. I can't imagine only 9% of patients getting treatment for a heart attack, for high blood pressure, for diabetes, some of these other things we've talked about. And the reason is not because they have been offered it and declined. So there's other studies that show that if patients with opioid use disorder are offered buprenorphine in the emergency department, 86% accept that offer. So it's not being offered is really what those numbers are telling us. So why not, right? Why isn't this happening in a more widespread way? I think we can talk about, stigma and bias and those things, and that is real. And there are other barriers as well, and it's important to recognize them. So one is training. Up until very recently, it was required to have a special waiver granted by the DEA in order to prescribe buprenorphine. And so many people were not trained to do it. When they came into the emergency department, their mentor providers weren't using it. Med school did not use to talk about it the way that they do now. And the combination of not being trained as well as the waiver requirement leads a lot of providers working in hospitals or emergency departments to feel like, or primary care settings to feel like this is out of scope. You have to be an addiction specialist in order to prescribe or initiate MOUD. This isn't my job, or it wouldn't be appropriate for me to do it. I think that's a big barrier. And then we also have just the culture. No one around me, no one around me is doing it. And so it must not be the right thing to do. There can be workflow barriers. The emergency department is a fast-paced and chaotic environment with lots of needs and limited resources. And if something isn't easy and isn't streamlined, it can be really hard to implement. A lot of times this isn't built into the workflow. There isn't like an electronic order set that's already built into to the health records, the computer systems. There may not be policies in place. It may not flow as seamlessly, and that can be a barrier. And the workflow around linkage to care. So we know that there are capacity issues in the community, and it can be hard to secure or to find an appointment for patients to know they're following up somewhere. And initiating these medications without the ability to continue them is something a lot of providers don't want to do, and certainly not being able to link to care, it puts a lot of weight on the patient to try to figure out how to navigate a healthcare system that is complex and confusing and really does have limited resources and limited capacity. And then experience. We talked before about how patients who have used MOUD describe it as really professionally satisfying, go from feeling like OUD is untreatable to it's one of the easiest to treat conditions. But if you haven't done it, you haven't done it. You don't have that experience to positively reinforce how beneficial these medications can be. So many providers say, I never used to do it, and then I used buprenorphine and it was the best. It was one of the easiest things I've done. My patient felt better so quickly. It was so effective. It was, a joy and a pleasure, but I didn't know that before I did it. So sometimes it's just about getting that first time, right? And kind of like exercising, where when you don't do it, it doesn't sound great. And then when you start doing it regularly, you're like, okay, wait, this really works. So the Washington State Healthcare Authority is trying to partner with a community, with hospitals to lower those barriers and to address them with a new statewide ED Bridge program, addressing the issues of training and experience and kind of feeling like you don't know how to initiate buprenorphine. We have clinical recommendations for the treatment of OUD, protocols that can help walk providers through step by step. How do I start? When do I start? Where do I start? We also have a 24/7 MOUD consultation line. So the ability to talk with another provider and ask questions on challenging cases or first-time initiations. Our program can help hospitals implement this work, right? Whether it's creating policies or protocols or figuring out how to bill for it. We're able to do technical assistance with hospitals and emergency department on the administrative end to get the workflows in place, which can include doing staff education, provider education. And we also have a 24/7 real-time appointment scheduling line so that the patient can leave the department with a date, time, and location for follow-up. A lot of so Scala Northwest is the name of the Washington State ED Bridge program. And one of the resources Scala Northwest has is scalanorthwest.org, which is a website that has a lot of our content on it, including protocols for the initiation of buprenorphine, methadone, home initiation, adolescent initiation, what to do if someone's withdrawal gets worse, if it's precipitated by buprenorphine. We also have pain management in the context of OUD. There's trainings, both pre-recorded and live, recommended discharge instructions, nursing considerations and education, and harm reduction resources. And these are all available on our website, accessible by anyone at any time to help walk people through initiating medications for opioid use disorder in the emergency department, and geared towards providers, but not only, you don't have to be a prescriber to benefit from the resources here. There's a lot of education geared towards non-prescribers. And I think that it can be really valuable to advocate for patients receiving to receive MOUD. And the clinical tools here are something that non-clinicians or non-providers can bring to the table and say, hey, I think this patient could benefit. And if you're not sure how to do that or need help walking through it, here's this site that could possibly help. One of the concerns people might have initiating buprenorphine is that we are needing to use higher and higher doses with fentanyl use disorder than we did with heroin or other opiates, and people can feel uncomfortable with that. So our protocols are developed by a multidisciplinary work group of experts across the state of Washington, and they're also supported by the Healthcare Authority, Department of Health, endorsed by Washington Society of Addiction Medicine, Washington American College of Emergency Physicians. So really trying to build confidence that this is something that is okay for them to do. And I think that can be a tool if you're advocating for your patient or if you are a prescriber. We also have that psychiatry consultation line. So anyone who feels like they need real-time backup from a provider can call the PCL line. It's staffed by UW psychiatrists and addiction psychiatrists. It is for adult patients only, so I'll caveat that, but it's totally free, both to prescribers and non-prescribing providers. So they will consult on recommendations for care, regardless of whether you're a prescriber or not. It can be used in any practice setting, so inpatient, outpatient, primary care, behavioral health, and they have the ability to consult on MOUD initiation, broader substance use disorder or polysubstance use disorder questions, and co-occurring conditions, and also general psychiatry. So, I'm bringing this up in the context of substance use disorder, but an amazing resource for any patient with behavioral health or psychiatric concerns, where their team could use some extra support or guidance. And then one of the resources that I want to get into a little bit is the scheduling line. So often either an emergency department is hesitant to start buprenorphine because they don't know if it's going to be continued or how it will be continued, or they'll start it and then a patient leaves and there isn't follow-up care, right? It doesn't lead to retention and treatment because the ability to actually connect and get into treatment isn't there. Or maybe a nurse care manager or a social worker is asked to call them back on Monday, and that is not, that's not always an easy connection to make. And so the ability to set up follow-up care in the department before a patient is discharged takes the burden off both the patient and the healthcare system to figure out how to navigate setting up that follow-up appointment, and increases the likelihood that patients are going to be able to benefit and continue the medication. So our scheduling line, participation is voluntary. It's open to hospitals and clinics statewide. So we're bringing in emergency departments to use it, but also any clinics or outpatient providers that are offering MOUD can participate as one of the follow-up sites. Does not need to be, a substance use disorder treatment clinic. Could be a primary care provider, really anyone who's OBGYN, anyone who's going to prescribe and continue medications can participate in our scheduling line as a follow-up site. It is totally free. So whether clinic or hospital side, there's no cost associated with our scheduling line, and there's no contractual requirements. So no one needs to, meet a minimum volume or offer a certain number of appointments or report back. There's not like data collection and reporting. People can stop using it at any time if a clinic, is offering up slots and is not working for them and they don't want to anymore. There's no contract in place. From the emergency department, once we have clinics and hospitals enrolled, really all it is in the ED is a 5-minute phone call. So call the line, give some very basic patient information, insurance, pregnancy status. We just want to make sure we don't connect people to a follow-up option that they can't meaningfully use. And then we will offer the ED staff and the patient a couple of different appointment options. Some will be brick and mortar, some virtual or telehealth, and just pick one, right? So emergency department, patient, pick the best one for them. They'll get the date, time, and location prior to discharge. We can also, if the patient opts in, can ping a peer. And so in addition to letting the clinic know that to expect this patient, we can notify a peer organization that someone was in the emergency department, they started MOUD, they want peer support, they have a follow-up appointment. Can you reach out to them? Can you find them? We will send out the patient's contact information, and it doesn't have to be a phone number or an address. We can free text. So hangs out here, right? Like, swing by on Wednesdays, right? Like we can kind of be very flexible as to what contact information means and looks like. And then the patient can opt in to either email or text reminders for the upcoming appointment. In addition to connecting the patient to services, it also lets the ER provider know how long they need to write a prescription for buprenorphine. So if the appointment is in 10 days, the provider knows that they can write a 10-day prescription, and there's no concern of, okay, we're going to discharge you, write a prescription for 7 days, and then you're going to call around Monday and you have to find an appointment before your prescription runs out. This allows that bridge prescription to be more effective. So website, consult line, scheduling, those are kind of the summary of the supports that Scala Northwest offers to address the barriers to ED, MOUD, and reduce the risk of death and poor outcomes that patients experience when they're not offered medications for opioid use disorder during those emergency department encounters. Some contact information here for the Scala Northwest program, and then also for the psychiatry consultation line that we partner with. Again, that can be used anytime by anyone in any setting. And so, really just want to plug that as an amazing resource. And some references because I threw, numbers and statistics at you. And I will pause there, and hopefully that leaves a couple minutes for questions.
Wonderful. Thank you so much, Liz. That was excellent. No questions just yet, but folks, we've got a few minutes still, so please ask them as you have them. While folks are thinking of any questions they might have, I just want to say thank you again. I really appreciate how you framed so many elements of your presentation, and I think having some of the provider satisfaction piece, I think, was really intriguing. And then early on, you framed like the emergency department as being one of the few spaces that has to accept everyone, and like how important that is. So just thank you for all of that.
Yeah. Oh, sorry.
Please, no, go ahead.
Oh, no. Well, so one thing I'll say on that provider satisfaction piece is that one of the principles of harm reduction is to meet people where they're at, right? If you're working with someone who uses drugs, it's not helpful to say, here are my goals for you. Here's what I think you should do, right? You're going to come alongside and say, what are your goals, right? Is there something I can do to help you reach them? So let's do the same for providers. Some of the principles don't apply, power differential is different, but we can come alongside emergency department providers. And instead of saying, you're not doing the right thing and it's because, you're stigmatizing this population and that's bad and you should love people who use drugs. That is not always the goal of the person that you're talking to, right? Like you may not be following their lead, right? You may not be meeting them where they're at. And when you can come alongside a provider and say, hey, do you want to have an easier shift? Do you want to feel more effective? Do you want to reduce mortality rates? Do you want to keep people from coming back to your emergency department? The answer to those questions are always going to be yes. Well, I shouldn't say that, but they are often going to be yes, right? So finding the goals, meeting someone where they're at, and then approaching this topic from that perspective, I think can be really helpful in terms of finding shared goals. And it can also just be kind of less shaming, create less defensiveness. I don't think people love to hear like your opinions and perspectives are wrong, so I just think that can be more supportive in terms of how we talk about this.
Yeah, absolutely. And again, you frame things so excellently. Like harm reduction goes a bunch of different directions and includes everyone at play there. All right, so we are seeing a question in the Q&A box. Is emergency room induction of medications for opioid use disorder appropriate for pregnant persons?
Yeah, absolutely. Yes, absolutely. Yes. So you're gonna have better outcomes for both the pregnant person and baby. Buprenorphine and methadone reduce all kinds of complications, risk of cesarean section, maternal death, fetal, stillbirth or premature birth, and absolutely an emergency department is an appropriate setting to do that. You can use the standard initiation algorithm. We are also finalizing our peripartum, kind of perinatal pregnancy specific algorithms. You can use the standard algorithm, but we are creating pregnancy specific ones that'll be up on our website as well. Yes, appropriate and needed.
Right, excellent. Thank you. Now, one of my colleagues sent me this question, saying that they've been told by folks who work in the field, specifically direct client services, that often when someone has been using opioids very heavily or stronger opioids such as fentanyl, that
Mhm.
the preference is for methadone over buprenorphine, saying that like buprenorphine or Suboxone can't touch their cravings. And do you know of research that backs that position?
Well, uh, there's kind of two answers to that. One is yes, methadone's a really effective medication, and it is very reasonable to prefer it. And methadone can be started in the emergency department as long as there's a methadone clinic or opioid treatment program to refer people to, right? So if you're in an ED with a patient who prefers methadone, great. If that is a resource in your community. Um, some downsides to methadone in the context of fentanyl use disorder is you have to slowly increase doses. You don't start at the dose that people are going to end up on. You have to work your way up. And because people are needing higher doses to treat fentanyl dependence, it can take longer for a patient to get to a dose that's going to help them feel better. Um, and for a lot of people, methadone may be more effective. I do want to say, though, that sometimes if a patient is like, buprenorphine doesn't work for me, buprenorphine has made me sick, I've had bad reactions, I don't want to go there, it can be really valuable to have a conversation with that patient. It is very likely that they were given too low a dose. So, and if you are given too low a dose of buprenorphine, it can cause you to go into withdrawal. It can make your withdrawal symptoms worse. It will not treat your withdrawal and cravings. Absolutely can make you sick. Absolutely cannot work. And what happened is the doses that were being used for heroin or for the prescription opioids, those doses are not appropriate for fentanyl. And it's worth having the conversation to say, hey, do you know what dose you were given? When did this happen, right? If someone gave you 4 milligrams of buprenorphine to start you off, probably may not have been that helpful. Our algorithms recommend that you start at 16, right? And go higher than that if needed. And so that can be a that can be worthwhile to explore as opposed to just being like, oh, okay, it doesn't work for you, especially because it can be challenging to access methadone.
All right, thank you. Thank you for that. And
Yeah.
I love the answer that more options are always better, like having as many options as possible to meet folks where they are. All right, just a few minutes left, but we've got another question in our Q&A box. If public library staff administer naloxone and reverse an overdose, is a good practice to recommend an ED visit to access buprenorphine. Sometimes we have to administer multiple doses, and I worry about withdrawals and also them going back to an overdose state.
So that really depends as to whether or not the emergency department in your area is reliably offering buprenorphine. So um, I wouldn't, I mean, so that would have to be something that like you really understand about the emergency department in your community. Um, so, yes, it's a great time to get started on buprenorphine because patients are already in withdrawal, right? Typically, you have to wait till you're in a little bit of withdrawal to use buprenorphine because it doesn't activate those receptors as strongly, but it binds preferentially. So the buprenorphine will go onto the receptor and kick off the opioids, the full agonist opioids. So you have fentanyl on board, you add buprenorphine, the buprenorphine takes the place of fentanyl, but it doesn't activate it as completely. So if you're not in withdrawal at all and your receptors are fully covered by fentanyl, then it can actually make people feel sick. It can make them feel worse. So, but post overdose reversal is this really opportune time. People feel terrible. Buprenorphine's not going to make it worse. It binds more strongly than naloxone, so it will kick off the naloxone and take that place and do some opioid activation, which the naloxone doesn't. Yeah, so it's a great opportunity, and you'd have to have the resources to do it. The comment about worrying about recurring overdose because buprenorphine binds more strongly, like is sticks to those receptors more than fentanyl does. It's going to be there when the naloxone wears off, right? Like you're going to have the buprenorphine there with its respiratory depression ceiling, and so it is safe to use post overdose. I feel like that didn't totally answer your question, but dependent on your emergency department, I guess.
Yeah, no, I think you covered it well. Well, thank you so much. Final question with
Yeah.
our 60 seconds remaining. We've just been asking everyone this as we wrap up. What is one action step you'd like our attendees and our viewers to take after watching this session?
That's a good question. I mean, I guess just consider having those conversations with whoever is in your network that is treating patients with opioid use disorder and not offering buprenorphine. To say, hey, why not? Right? Um, and also maybe to say, hey, would you do this for another condition? Would you have someone, with a bipolar condition you didn't offer medication to, right? Like, I think that question can be really impactful. Um, And so I think that might be a place to start. Another thing that I will plug is that if you do work for an organization or with an organization that offers buprenorphine or MOUD, please feel free to reach out to Skull Northwest and consider becoming one of the providers in our network that is able to help take care of these patients.
All right. Well, thank you so much, Liz. Folks who are still on the line, please check out our next and final session of the day. That's going to be at 2 o'clock, and that's all on. Let me make sure I get the full title right. Medication overdose considerations for older adults. And Liz, before I end this particular session, I just want to share some of the really positive feedback in the comment section. A lot of thanks for you for working to remove shame as well as improving patient and caregiver satisfaction. Another one saying how much they appreciated the presentation and your compassionate and clear framing of addiction as a treatable disease. It's also so wonderful to hear the addition of peer support as an option. Well, Liz, thank you so much for joining today, sharing your expertise. And folks, we hope to see you in now 13 minutes for our next session. Take care,
Yep.
everybody.
Thank you so much.
Thanks.